companies in the industry, and currently he's managing director of the Navigant Center for Healthcare Research and Policy Analysis, where he's leading a team of analysts and assembling industry issues and regulations relevant to hospitals, medical groups, health insurers, drug and device manufacturers, and policymakers at the state and the federal levels. He authors Pulse Weekly, which is a weekly health reform newsletter, a monthly column for health and hospital networks, and has published 3 books and 250 articles. You'll actually see him as a regular contributor on MedCity News. I'm excited to hear what he has to say about the current landscape. Please welcome Paul Keckley.
Is it okay if I stay here? You okay with that? Does that mess things up, Chris? It does? You want that up there? All right. To my chagrin. I just tested a new $77,000 brand new knee on that move. I'm going to do 3 things. I'm going to do what the conference planners asked me to do, which is bring you up to speed on some of this health reform stuff. Second, I want to spend a few minutes on kind of investor themes that can be derived from all that's going on in DC, as well as we have to talk about the budget process, and we have to talk about the EU and where we think Janet Yellen and other people are going with the central bank. And then lastly, I'm going to open the floor to any and all questions. So is that a fair agenda for this group? You okay with that? No PowerPoint. How's that? I was reading with great interest the article about Twitter the other day, and the CEO disallows PowerPoint in any meeting. He said, we're not communicating anymore, we're powering through PowerPoints. And I think that's pretty true. So how many of you have read the Affordable Care Act? Well, I'll just kind of start with the Reader's Digest version of what's in it. I recall in DC getting a call from the people in the White House Office of Health Reform the first Friday of May of 2009, and they said, you know, we just had a photo op with the president. We had the American Hospital Association, American Medical Association, America's health insurance plans, pharma, AdvaMed, have a kumbaya moment with the president, because these 5 big trade groups have agreed that collectively we'll take $2 trillion of cost out of the healthcare system for the next decade, and at the same time we will enhance quality and improve safety of the system, and we'll protect a private system. And all 5 of those trade groups signed on. And then the call was, so now the hard work, you need to get these folks together and let's talk about how they're going to do it. And I recall 5 weeks later, as the president's heading to the Middle East for his first junket as president, we had to deliver a set of recommendations from that effort. And I was facilitating this in my role as being completely independent and colorblind. I'm neither blue nor red. I look at the health system through the lens of data. And I try to understand the intended and unintended consequence of action or inaction from a policy standpoint, from an industry trend standpoint, and certainly from a capital markets perspective. So I started with no expectation of where we'd go. And we had some very interesting discussions. What about, for instance, taking Bush 43's leftover TARP money and using that money to buy excess capacity in the acute system from the operating cost structure that we're bearing? At that point, we were operating about 3 beds per 1,000. As everybody in here knows, we need 1.1 to 1.6 bed per 1,000. That additional capacity is cost. So why don't you take leftover TARP money in markets like Baltimore and Detroit and Buffalo and places, and let's pay these not-for-profit systems at book value and take that capacity out of the system. And then, of course, you find out that that's fine as long as Congress says none of the jobs go away. And I could repeat that story around about 50 different things that we studied. What we might do to improve the performance of the healthcare system without compromising safety and quality, reducing cost, and protecting a private system. That was in May of 2009. About a dozen things that came out of that process are in the Affordable Care Act. As all of you know, what happened then was fascinating. Congress adjourns in August of 2009. It is actually just a recess for the summer. And then you start hearing about these very inflammatory terms like death panels, which was a very simple thing in one of the House versions of the law that said, you know, if a senior at the end of their life wishes counsel from their primary care provider, here's a code to which that primary care provider can bill for that 1-hour consult. That became death panels. And I think it's been, since then, very clearly, kind of the degradation of a public discussion that's thoughtful about reforming the healthcare system. And we've had all sorts of pandering to the fears on both sides, and you can use all kinds of code words, if you wish, to inflame the base. And I think that's all the more important as we enter the 2016 election cycle. So here's what's in the law based on fact, based on what's actually in the 977 pages of the law. If you read the law from front to back, you're going to see two major efforts. You're going to see one part of the law that says we have to rebuild the business model of the insurance industry because it's fundamentally immoral. The president used the term, we have to keep them honest, many, many times as health reform was being debated. The polling says that most people don't have a strong, warm feeling about their insurance company, and trust can be an issue, and a perception to some extent, with the Blues having a slight advantage, that they're all pretty much alike. And what the law did around insurance, if you recall, is it said we need to make sure people can be covered without pre-existing condition. We need to make sure that 26 and unders can be covered on a parent's policy. We need to not discriminate against women in terms of their premiums and costs for the same product bought by men, and so on. And the law said we need to expand access to insurance. So it had two major elements. One was to make sure that states had a mechanism to expand their Medicaid program. And that's in the law, a provision that says that eligible individuals who are citizens are eligible up to 138% of the federal poverty level. And we've had now 27 states to move in that direction. And then the other part of the law, which has gotten most of the attention, has been how do we create an affordable, accessible insurance market for individuals in small companies so you can buy policies. And what the law said is we'll create these exchanges. And basically they were borrowing from two that were already operating, one in Massachusetts, one in Utah, and they said we'll create these marketplaces. And I remember when we initially had that discussion, the bet was that just about every state would want to operate its own exchange. And there may be 6 or 8 states that wish not to, and they're more than likely the really deep blue states. But the rest, go figure, would probably want to go the route of developing their own exchange. Why would you want the federal government, after all, to do that? And so the law basically said, as we're making these other changes, and you're changing your business model, in 2014, we'll kick off these exchanges. And for 3 years, we'll ramp up the exchanges so that a high proportion of people who are eligible, between 138% and 400% of the federal poverty level, can buy an insurance product and, based on their income, be eligible for a tax credit, which is paid to the insurance company to offset your premium. That's the law. As we're here today, through the close of the exchange round 2, healthcare.gov did not crash. It was in 37 states. 11.7 million people have enrolled either through the federal or the state. It's 8.8 through the federal, the balance through the state. And right at 86% of those who have gone to the exchange are eligible for a subsidy based on their income. And about 7+ million, I think it's 7.4 million, who went to the federal exchange to enroll are eligible for a subsidy, which, if King versus Burwell plays out for the plaintiffs, that subsidy goes away. And now we have a number of things that kind of trickle down, intended and unintended. So that's kind of where the insurance part of the law sits today. And don't forget that there's this big bogey sitting out there in 2018, which is the Cadillac tax for high, expensive insurance products for big companies. And after 2016, the states have some latitude as to what they do around their programs. So that's the insurance part of the law. Basically, create an affordable insurance market, expand access, make the business model for the insurance companies moral and transparent, and hopefully we've gotten through 2 election cycles. Remember, this is passed in March of 2010, and all of these insurance changes occur from 2010 to 2016. So it's front-end loaded. And then the other half of the law says we have to change the delivery system, because the delivery system is not immoral, it's just screwed up. It's fragmented, it's inefficient, it has the wrong set of incentives. If you think about cost, it's volume times price. And what the policy of the federal government has been is to modify price. Just change the fee schedule to nullify cost increases. And then what does the delivery system do? It does a workaround to do more. So what in the law is the premise is the following. The delivery system has to become fully integrated, where we don't have fiefdoms of post-acute and acute, subacute. There are 9 subsectors of post-acute alone. All have different technologies, all have different business models, all have different regulations around quality and safety, fraud. We've got to somehow create Sam's Clubs that compete with Costco's that are fully integrated across the healthcare system and defragment the system. That's the reason that even dating back to the Stimulus Act in 2009, the money that was in the Stimulus Act, the $27 billion for meaningful use, has not been rated. The reason meaningful use, connecting the system through information technology, is still seen in Washington as a necessary investment is you can't defragment the system if everybody does their own thing. And you can't extrapolate data that can be useful. Just in the past 2 months, you found these fascinating conclusions coming from CMS that too much of the data in many of these sectors is self-reported, Chris. And you're just trusting the operators to give you their numbers. Does this sound a little bit like the VA and the problem they had around self-reporting of wait times? Is systemic across the system. So HIT is embedded and presumed in that part of the law. It doesn't go away. So therefore, you do three things. One, you defragment, you bring it together. Two, you change the incentives from volume or fee-for-service to value or value-based purchasing or performance or outcomes. There are actually 5 major elements of the law that kind of get right to that. How do you shift the incentive? And then third, we want to make sure that we're only paying for things that should be done instead of anything anybody wants to do. And if you think about this, had you just done the first two, you can still game the system. And we're not the only system in the world that's faced this problem. When you look at other organized systems of the world, about 20 of them, there's a mechanism in those systems of care where the right thing to do, based on signs, symptoms, risk factors, comorbidities, and patient values, there is some direction as to what works and what shouldn't. Unless we forget, according to IOM, according to Dartmouth, according to the RAND data, probably 30% of the spend in the system is for things for which there is no scientific evidence of value. We do it because we can. We do it because we can. So the law, thirdly, says we've got to create that platform for determining what should be done and shouldn't. And here's the interesting part of this section of the law, and we've got to make this accessible to Joe's six-pack. It can't be controlled, as Steve Brill said in his piece a couple of months ago, we can't let the fox run the hen house. We can't let the insiders control that information. It has to be public. And even in the enabling legislation to the law, we're getting into these very dicey questions of just how do you do that? How do you get this information in front of someone so they can act on it in a way that's meaningful? Knowing, as all of you know, that the more we know from evidence, the less we know. The more you look at these algorithms, the less you determine their predictive value. The more variables you put in on signs, symptoms, risk factors, comorbidities, the less precise. But then from a cost standpoint, wouldn't a policymaker then conclude if the evidence is not clear and all things being equal, we would start with the cheaper of the options and then work our way to the more expensive? That's a rational position for a policymaker to take. It's not a rational position for plaintiff's bar that said, but you should have started there. So that's part of the tension in the system. So that's kind of the law. We've had 53 changes to the law since it was passed, most of these through administrative order, executive action, or inaction, where you choose simply not to implement a part of the law, and you can do that by virtue of how committees have to enable this to be done. So where we are is halfway through. In 2 weeks, we have the halfway point since passage. Isn't that hard to believe? We're 5 years into its implementation. We're not quite halfway through its implementation. We found some pretty interesting things. We found out these accountable care organizations, these Section 3022 accountable care organizations, don't work quite as well as people thought they would. We're finding that bundled payments may be promising, but bundled payments that involve the drug spend and the post-acute spend are really problematic. When you look at the cancer spend, and you try to bundle at least the 4 big cancers or the next 8, you quickly get into the drug spend and medication management and formulary design and medication adherence, and quickly into a gray zone of alternative health, where often the science is not very strong. So bundles seem to be promising, but now, as of 3 weeks ago, we've announced we're moving from the simple total joint into the more complicated, like the OCM model, the oncology care model that they've just announced. Patient-centered medical homes has proven to be a question. If you've seen one, you've seen one. It's not that the theory isn't sound, it's that the implementation seems to be so highly variable. And if I said to you, primary care is the key to the kingdom and we should just capitate the U.S. healthcare system, and we've got a very robust ROI to prove that's the right way to go, over how many months and years do I allow you to count the unnecessary emergency room visits and admissions that are included? Is it 3 years? Is it 7 years? Is it 10 years? We just don't have the methodologies quite yet. So what's that mean from kind of an investor thesis standpoint? You know, we've got data from the CBO this week. And the Congressional Budget Office says we've got good news and we've got not so good news. And of course, the not so good news is not the news that was actually reported. The good news was that healthcare spending is actually, over the next 5 years, about 11% below what we'd forecast. And a lot of that's the result of medical inflation has been a little lower. Even though drug spending's up 12%, it's been a little lower than forecast. But we've had some other things. Not as many people have signed on for enrollment. So the outflow of money for subsidies is not what we thought it would be. We're at about 40% of the eligible people who would be eligible for a subsidy that actually enrolled and expect to get a subsidy. So that's money that's not being spent. As companies have dropped coverage, the Cadillac tax, which was to be a big number in the law, will be a much lower number. So we're finding out that healthcare spending is still going to be an issue, and it's still going to exceed the GDP of this country by at least 2% per year. But who's spending it and how that pain is felt across the system is very complicated and not well understood. So let me unpack that a little bit. Every employer in this country right now that provides a benefit, which is about half, largely in a few of the same industries, says I've got to do 4 things. I've got to go to a high deductible product that still passes the muster of the law. So the first $5,000 or $10,000 is going to come out of pocket to the average household whose income is $51,000 and unchanged since 2009 in discretionary spend. Second thing the employer does is he says, I want to make sure that I'm getting to narrow networks so that I don't provide care to everyone through the docs they want or the hospitals next door. And then even super narrow networks where companies like a Walmart or a Lowe's have chosen to go with certain provider organizations instead of that staying local. All healthcare is local is mythology in the future. A third thing employers have done is say we've got to zero in on our employees who are about 20% of our workforce who are at risk of being a big ticket item. They're the train wreck, they're the high cholesterol with a likelihood of a heart attack and so on. So we've got to start mitigating that risk. And then lastly, they're saying to the rest, numbering, depending on the industry, 70 to 85% of employees, we've got to provide you some basis for understanding your own health, because after all, we are shifting the risk to you. We are not intending to be in the middle of decisions you make about your health. And by the way, on a narrow network, you may choose to stay at home on that narrow network, but we've used a reference price. So the difference in getting that done 200 miles from here and getting it done at home is part of your out-of-pocket. That's one of the most significant trends impacting the future in the U.S. healthcare system. The strategy of employers to force individuals into very uncomfortable and sometimes unsustainable decisions they have to make. All of you saw this week the proposal about the credit rating agencies and how they were going to reclassify medical debt on credit cards that show up in your credit score. Let's not forget that medical debt is the single greatest source of involuntary individual bankruptcies in the United States. And often this debt hits your credit card and your score on a transaction between an insurance company and a provider, and you're not even aware. Did you know that? So we've really got a potential here for a massive discussion about how do we protect consumers from debt of which they're unaware? And how does the system rationalize a transaction? I just mentioned my knee. I will tell you anecdotally, my biggest surprise in this whole thing, besides 51 hours in the hospital at $55,000, was that in the course of that process, the hospital sent my bill to the insurance company before I saw it, and then announced to me that my insurance was pending. And I looked on my bill, and 4 of the 11 line items were things I've only been in this business 40 years. I'd never heard of them. And I asked, what are these things? I actually paid a greeting fee to escort me to the operating suite. I can follow instructions. So I found that was fascinating in the context of the law. The disclosure and the openness, transparency is a central feature of the law. Let me mention 2 other things that kind of frame an investor thesis. So we're going to have a dramatic shift in the way the insurance market looks over the next 5 years. And with that, a very incredible set of pressure points on discretionary spend of the U.S. consumer's pocketbook, at a point which not only is there mounting medical debt going up for middle America, but as the central bank, as the Federal Reserve, raises short-term rates, which seems certain, right? Certain by middle of this year, we expect the borrowing rates for consumers for their appliances, for their cars, to go up. And if that weren't difficult enough, U.S. companies that are exporters are going to raise their prices because of the volatility of the EU and because the emerging markets are not performing the way we thought. What's that all compound to? Our economy is built around consumer spending. It's 70% of our GDP. In the near term, the signals are that consumers are going to be hard-pressed, and not to your surprise, the way consumers make decisions about health care is not rational, nor are the transactions transparent, nor is there relationship between price and quality. And as a matter of fact, lots of that debt goes unpaid. It's bad debt. It impacts the system. So I look at the system kind of sector by sector, and I've kind of through my career ended up thinking of healthcare as 17 different buckets of activity, and I think through what's the technology that's disruptive, what's the source of capital for that market, where do they bump into new and other competitors? And what's the short and long-term strategy in a sector? And I can kind of tick off the big sectors and think through the obvious. Number one, this discussion of financial versus strategic investor, I'm sure you've had. If the question's posed, is this a time for the strategic investor only? Are the financial investors out of the market? I think not at all. I think the financial investors see tremendous opportunity in healthcare simply because over time it's a sustainable engine. It drives growth. You have to figure out, like a whack-a-mole, which part of the industry's up and which part's down. But it does, over time, outperform the rest of the economy. And for 37 years, health spending in this country has exceeded the GDP by at least 2% per year. So even if GDP's down, healthcare spending is above that. When the economy in the U.S. is down, healthcare does well. When the economy in the U.S. is doing well, we do better. Go figure. So as an investor, we're all in, both financial and strategic. When you look sector by sector, you've got some interesting bifurcation. Not surprisingly, Fitch, Moody's, and S&P in the fourth quarter downgraded the non-investor-owned hospitals. They basically said, you folks in the not-for-profit hospital world, gig is up. Bad debt's going to increase. You can't afford the capital to stay competitive. Just consolidating to stay afloat doesn't reduce cost and it doesn't drive value. So you're going to have to find a new strategy. So I think there's a real challenge if you're looking at the not-for-profit, but that's also the opportunity. That's one of the ironies to me, is that anyone outside this industry sees more opportunity and more sunshine than the people in the industry that just see rain and dark clouds. And this industry is ripe with opportunity. If you look at the drug side, this is, for us, fascinating to see the barbell. The fact that a Sovaldi can end up with $10.28 billion of sales last year alone. 12 of the new drugs on the market, $100,000 per episode of care each. Specialty pharma looks like it has no sign of slowing down. There'll be some pressure on that, and it will spark an Occupy healthcare reaction in this country. But the fact is that it sits there in a pretty unique position with some short-term sustainability. But what people also miss is on the level 1 formulary, generics have also had a good run. They're actually increasing their margins and they're increasing their utilization. It's now north of 85%. And there's a pretty strong global opportunity for them, even in a depressed EU and other markets. The device is a different story. The medical device industry, which all of you know is about 3% of the spend in the U.S., faces two pretty strong headwinds. One is the Navy SEALs in the FDA are convinced that the device folks have a lot to hide. And they're asking for science. It's no longer good enough to say you're essentially equivalent. Now you got to provide science. And a lot of that is cost that many of these companies have not. By the way, 6,000 medical device companies in the U.S. 6,000. A lot of these are very, very small companies. And the second headwind is efficacy and effectiveness. We're finding out that much of what we use may have an incentive for its user more than a benefit for the patient. And so you're going to see a stepped up amount of attention to private inurement and a lot of attention to physician ownership, which is in the law, but kind of muted. And I think that becomes much more prevalent. Commercial health plans. What's that future? It's very interesting that profitability in the commercial health space, especially among the 6 big investor-owned health insurance plans, has done extremely well, thank you very much. And there are some uncertainties around that sector looking forward. It's not surprising that the Medicare Advantage number came back the other day, and a net adjustment of 1.1% when they thought it would be cut. Part of the reason is the Medicare fund didn't spend as much the past 4 years as we thought. And Congress doesn't want to take any risk, so why cut something that's popular? But the long-term cloud hanging over the insurance industry is about its value proposition. And here you'll see a different story depending on the company you talk to. You'll hear Mark Bertolini at Aetna say, we want to be the Intel inside the U.S. healthcare system. That's the justification for their purchases of Medicity and these other IT platforms, and their effort to be the ACO operator inside provider organizations. You see Humana doubling down on its Medicare work, but also diversifying. All 6 of the big investor-owns have bought major medical groups in the past 2 years. And all are making efforts to somehow become partnered with, in shared risk models, the delivery system, the hospitals and the doctors, while the doctors and the hospitals are saying, if I play with you, will the other plan retaliate? So it's a pretty dicey time, a lot of uncertainty in the commercial health insurance space, but you never bet against them. Never bet against them. And the investor-owned hospitals are probably the bright light. If you read just about every analyst report and you look at their quarterly earnings, they're doing well. They do well for 3 reasons. They tend not to be operating businesses that are prone to very difficult to manage populations. You'll rarely see burn centers and organ transplants in a lot of these investor-owns. They operate incredibly efficiently. They know where every nickel is spent. And remember, they have a central banking function in their companies. They can allocate capital appropriately. They can move all the hips in one market to 2 places where they did that in 6 previously, and so on. So they have an advantage in the market from an investor view. So I'm going to stop there and take the time we've got remaining and just see what questions you've got about this affordable care stuff or how it starts to trickle down. Yes, sir. I like that accent. As a cracker, I'm always jealous of someone that sounds good.
I understood up until yesterday that we were spending about 15% of GDP on healthcare. I was reliably informed by a substantial investor that that's now 19%. You said 2 things. Firstly, that's abating and gave some reasons for why that might be. But you didn't mention the common theme which appears in the press nowadays, which is really that's because of, particularly from the right wing, which says that's because the economies have been in terrible shape. Yeah, and as soon as we start picking up, that will grow. And the other thing is that it's clearly unsustainable that it's going to continue at 2%. So it's an encouraging trend. But I suppose my real question is, what's the likelihood of that abatement of inflation continuing?
Well, remember in the law, we have a policing mechanism called the Independent Payment Advisory Board, that when it hits a certain number, that they automatically put a lid on it. And that doesn't appear to be any time in the near future because the market does seem to be working some. But what's working in the market is not the Affordable Care Act to depress that price, to depress the cost. What happened were a combination of producers kept their medical inflation rate adjusted at about 300 basis points or less. So in your supply chains, you didn't see the enormous increase. Caveat, specialty pharma, caveat, generics. Otherwise, second, we had declining utilization. Don't forget, since 2007, the downturn, elective procedures are down about 20%. People just didn't have the copay and deductible to do it. And third, Ironically, the new enrollment has not produced this windfall of pent-up demand that people anticipated. So these 20 million or so people that got insurance through the exchange or expanded in Medicaid haven't hit the hospital as hard as we thought. They've hit clinics, but they've not hit hospitals, which would have driven up cost. There's no, and I've got, we look at this data every day. There are no rational models that say somehow there was magic in the accountable care organizations and it saved a boatload of money. You can't attribute the slowdown to the Affordable Care Act objectively. And if you forecast spend in the future, you have to make one big bet. You have to bet that we'll follow a traditional trend of about 2% above GDP. That's medical inflation plus increased demand, plus it's 10,000 people a day aging into Medicare. And by the way, if you follow the Medicare data, per capita spend in Medicare has been pretty flat. But it's the aggregate spend that's kind of jumping every year. So I'm pretty comfortable that we're going to see 5.5% growth in health spending year over year. If the Fed says we can get to 2.7 this year in our GDP and we can maybe inch up toward 3, fine. That still means that every sector of the U.S. economy will be subsidizing shareholder returns in this industry, right? It means that net effect of that is that the other major industries will subsidize healthcare, and as an investor, that's probably good. What else? Yes, sir.
So I guess my question would be, in light of so much change happening, what are your thoughts on the parts of the healthcare technology ecosystem, I suppose, or the healthcare ecosystem in general that sort of sit on the periphery or the ancillaries? On the one hand, things like paratransit, emergency services. On the other hand, health IT, meaningful use, the fact that ICD-10 is still sort of flopping around. Things that are supposed to serve this changing ecosystem,
yeah,
that is in turn changing around them.
Yeah,
so,
if I were a betting man, which I am just around my $10 golf game on Saturday, I would say anything that drives the cost curve down is where I make my bet, and quality and safety is about hitting the mark but not trying to exceed the mark. And I'm going to put that in this context. Quality is something we've used in this industry to justify everything we do. And then we want people to accept the fact that in our model, we put quality in the footnote of this is over 60 months or 72 months or it's 10 years. The market does not have the appetite for the highest quality. It will accept at the 90 or 95th percentile, the threshold, but it wants 100% certainty around net cost reduction. So where do I see opportunities for net cost reduction that are meaningful in the short term, that don't compromise this 90 or 95% threshold? We've got huge opportunity to reduce unnecessary care in hospitals. The data is there. We're doing hips and tests and procedures that never should be done. If you go to the OIG.gov website, you'll see a lot of opportunity there to see how the Fed is thinking about this. Now, what's the entrepreneur's opportunity? It's the predictive model. It's the analytics that look at that chart and associate that pattern of care with unnecessary care. And that those companies are emerging, and they're pretty impressive. We've got the most egregious fraud and malcoding in a couple of the sectors of post-acute care. And that's another low-hanging fruit. SNF, long-term rehab, LTAC have some pretty difficult numbers. We have a void and lack of real, I think, precision in predicting who that 20% are in the employer population who represent the train wreck within a short period of time. That's still an area for investigation. Is there money to be made in the consolidators? Good news, bad news. There's certainly money to be made as an investor in the consolidator, so long as the result of the consolidation is the synergy upside. It's the dramatic reduction. And the data says that when hospitals are merging into systems in markets, their costs don't go down. Yesterday you had 2 marketing directors. The next day you've got a marketing director and someone with a new title. So I think there's an opportunity on the arbitrage around the synergy, if that's in fact the result, and the data says we're not seeing a lot of that, and so on. I would not, I'd be remiss if I didn't get to this. We're also battling a question of what's the right model for wellness and healthy living. There's nothing that bothers me more right now than looking at model after model around wellness and healthy living, or a term I hear a lot, population health management, and then trying to find the business model that delivers solid value. And I think that's one yet to be defined, candidly. And I don't know how it's going to fit into this broader ecosystem. I know we're going to have to find it, but it's simply just not good enough. There are about 160 companies selling a pop health management program right now. And you look at them and they're all over the place in terms of business models. But that just kind of be a start. What else? They're going to flag me on my time here. If there's something else about the Affordable Care Act or what you might expect. Yes, sir.
Tim Hannon, I'm a physician. I'm from Indiana, so I have no accent, so that's not interesting.
Indiana's a good place.
Yeah, I've been within the health system. I worked in the DOD, work at St. Vincent, Indianapolis as an anesthesiologist. I've been on the audit committee of St. Vincent Health for 11 years, and I've been an entrepreneur consulting in this space. My personal opinion, probably like yours, is there's still a lot of slack in the system, and it's going to take a long, long time to get it out. So for people that are innovators, I think there's a lot of opportunity. The question, I think you partially answered it. You've got this God's eye view, and you've talked about investment opportunities. You've talked kind of a bit about analytics being, the opportunity. Is there a killer business model? Is there a killer technology that you see? Because we also have entrepreneurs here in the audience.
Well, I'll tell you where I look. I look for that next big killer app that gets the kind of Cast-like type valuation, if you want to pick one, that's completely irrational, and congratulations to Gino for pulling it off, are the convergence of clinical and financial information in a mobile environment. What we've got right now are the worlds of clinical data sitting in one set of clouds, and we've got the financial sitting in a legacy set of platforms, and we haven't seen that convergence of the two. And let me further complicate this, where I can also capture interaction with alternative providers, not just traditional doctors, hospitals, labs, and pharmacy. And remember that the alternative world, depending on which numbers you pick, is 8 to 13% of the spend. 8 to 13% of the spend. So why are we not surprised that CVS and Whole Foods and a variety of other people aren't looking at this just as seriously as we are? So my general belief is the killer app is going to be that convergence of clinical, administrative, and financial information with algorithms that are built in around your genotype that allow me to know what my treatment option is and allow me to choose the provider that follows that treatment plan that maps to the insurance that I selected through either a private exchange or other, and that is delivered to me on almost the same model as my cable bill. I think that's, well, there's a lot of, my son left Vanderbilt in emergency medicine to my chagrin and went to Microsoft back in February. And I was shocked, and the more I've learned and the more I study that world, the people outside our industry are not at all intimidated by all the stuff that we seem to be paralyzed by. They seem to see it as a huge opportunity. So I'm following as closely as I can the private equity folks and these strategic folks that look from the outside in at this industry and say, there's a lot more upside than downside. And I think that's kind of the lesson for maybe all of us. I'll say this finally, because we're out of time. On the Affordable Care Act, don't be surprised if you hear consistently that we're going to repeal it. Let you raise money, let you send out letters. But let's just not forget that to override a presidential veto, even if the Senate were to have 60 votes and pass a law to repeal the Affordable Care Act, goes to the president vetoes it, comes back, and then you've got to have 2/3 majorities in both houses to override the veto. So like it or not, that is the law. And it has hanging chads on every page, at least 300. But it is the law. And that's kind of the regulatory framework we're going to kind of work from, at least for the next 3 years at a minimum. Thanks very much for your time.